Hi, I'm here today to do a demonstration for a newborn head-to-toe health assessment. First is we're going to be perform our hand hygiene. Second is we're going to be verifying the patient's identity. How we do that is we check the wristband to make sure it matches the mom. And after that, we can go ahead and start our assessment. We can uncover the patient to make sure the baby will stay warm underneath by leaving the cover. Next, we're going to be checking for the baby or the infant's level of consciousness. If the baby is sleeping, we consider that a quiet alert. If the baby is actively moving around, we consider that as an active alert. And if the baby is crying, we just consider it as crying alert. For on this case, our baby is sleeping, so we consider that as a sleeping alert or quiet alert. After that, we can go ahead and start first our assessment by auscultating, and we'll do the temperature last. Since the baby doesn't like to be touched, often they get annoyed, so we do that last. Auscultating, we start with the heart. And using the Belafere stethoscope, or if you have an infant stethoscope, we can go ahead and use that. But for our scenario here, we're just gonna use the Belafere stethoscope to listen to the baby's heart sound. Usually we listen to the baby's heart for 1 full minute, and it's usually between 110 to 160 beats per minute. All right. After the heart, we're going to be listening to the lungs. We're going to be listening to the lungs on both sides. And again, using the Belafere stethoscope, you can go ahead and listen to the lungs. After the lungs, we can go ahead and check for baby's respiratory rate. We just check for the rise and fall of the chest, and usually that is between 30 to 60 beats per minute, or 30 to 60 breaths per minute. After the respiratory rate, we can go ahead and listen to the bowel sounds. By auscultating the bowel sounds, we're going to check for all 4 quadrants. So start at the bottom. Okay. After we are done with auscultation, we can go ahead and check for the head and the hair. By checking the baby's head, I'm just going to run my hand or finger through to feel for the suture line. And usually for the baby's head, the suture line, you can feel on the one on the top, it's called corneal suture, and the one in the middle is called a sagittal suture. And at the same time, while I'm feeling for the hair in the head, I'm checking for the baby's fontanelle, and that is usually it's soft or firm. After we check on the head and the hair, our next assessment would be checking for the eyes. For the eyes, I'm going to be using my pen light to check for the eye and the pupil. So we're just going to be shining our pen light through on each eye, and try not to force open the baby's eye. And next one is I'm going to be checking for the ears. And for the ears, we just make sure the ear is aligned on the eye and make sure they are symmetrical. Next is I'm going to be checking for the nose. Usually the nose is, babies are usually obligate nose breathers, meaning they breathe through the nose. How we check for the nose is we're going to be occluding each nostril at a time to make sure that their nose or their nostrils are functioning well. So occlude each nose. Okay. After the nose, we're going to be checking for the baby's mouth. And on this one, I'm going to be using my gloves. I'm going to use my glove finger and put it inside the baby's mouth to check for the palate. I just want to make sure the palate is intact. While I have my finger inside the mouth, the baby is going to start sucking my finger, so I'm also checking for the baby's sucking reflex. After checking for the reflex, we can go ahead and brush or stroke baby's cheek, and that's what we call a rooting reflex. After the mouth, We're going to be checking for the baby's neck, just to check for any signs of webbing, and also check for the chest to see for any discoloration. After the neck and the chest, we can go ahead and check for the baby's arm and hands. For the hands, we just make sure there are 5 fingers on each hand. So 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. And at the same time, I'm going to be checking for a reflex. It's called it's called palmar grasp reflex. This is when the baby's, when you put your finger, the baby's hand will curl up. And then at the same time, we're checking for the reflex to make sure that the arms or the forearms are they are flexed, or what we call our fetal form. All right. After we check the arms and the hands, we can go down here and check for the legs and the foot. And on the legs, you just make sure that it's symmetrical and the length are equal. And checking on the baby's toes, we also check for 5 fingers or 5 toes. So 1, 2, 3, 4, 5, and 1, 2, 3, 4, 5. And any extra digits on the toes is called, that is an abnormal. It's called polydactyl. So that will require surgery. Next one is, while I'm checking for the baby's foot, we can also assess for the soles of the feet. And if I put my finger through the sole on the feet, the baby's foot, that is called a plantar grasp. Now, if we stroke the baby's foot on the sole of the feet, that is a sign of a Babinski reflex or Babinski sign, and that is when the toes start flaring or fanning out. Okay, so after the legs and the feet, we can go ahead and check for the baby's genitals. So for genitals, if the baby is a female or a baby girl, we'll usually check for the clitoris, the labia minora, and the majora. And we usually check for the diaper. If you happen to see any pinkish blood, that is perfectly normal. That is called a pseudo menstruation. That just means that the mom's hormones are still circulating with the baby. And if it's a baby boy, we check for the genitals, we check on the penis. We usually check on the meatus, and that is where the urine comes out, just to make sure that the meatus is on the tip. Also checking for the genitals, we also check for the scrotum. We check at the bottom just to make sure that the testicles are descended. And then after the genitals, we also check for the baby's urine. Usually for first couple hours of life, baby's urine is color dark amber urine because they are more concentrated. And also the baby's bowel movements. The first stool we usually check, that's what we call meconium stool. Meconium stool, they are greenish, blackish, or greenish black tarry stool, and that is, and it's very sticky, and that's perfectly normal. And then after a couple hours or after a couple days, depending on the baby's feeding, if they are breastfed or if they are bottle feed, the stool varies as well. They became brownish, soft, or yellowy. Just checking on the bowel movement to make sure everything is normal and it's not diarrhea. After we check the genitals, we can also assess the umbilical cord. Now for umbilical cord, usually we just assess the site just to make sure there is no redness, swelling, or bleeding. The cord usually is thick and shiny, so first couple hours of life, they are thick and shiny. Now if they're a couple days old, it will shrivel up. After we check the umbilical cord, we don't pull or tug. We usually tuck diaper out, and that's very important. We don't pull or tug the umbilical cord. Now after we check the umbilical cord, we can go ahead and check the baby's back. At the baby's back, we are only checking for the curvature of the spine to make sure it's well aligned. And also we check the baby's bottom. We usually check for any spots or any dimplings. So if you happen to see any greenish or brownish birthmark, that's what we called a Mongolian spot. Mongolian spot is a normal birthing mark for the baby. Usually will resolve by itself. All right. And then we do the assessment last. Is we're going to be checking for the temperature, and how we do that is by using a thermometer. We're going to be putting the probe on the armpit, and then just hold the arm down. Usually baby's temperature, that will be around 97.7 to 99.5. All right. And we are finished with our assessment. We can go ahead and cover up the baby or swaddle it up. And we can go ahead and give it back to the mom. And that is it.